Hi, I'm Tina. I'm one of the critical care consultants at Manchester Royal Infirmary, and we're just going to talk through our plans for proning patients with COVID-19. So first of all, in each critical care area, we're going to have a proning box. On top is what's in each of the grab bags inside, and inside the box will be a grab bag, which is here, which contains all the contents that the nurse will need to get the patient ready for proning. There'll also be a how-to guide which will stay at the patient's bed space, and also a checklist which involves the information on the personnel you need, the equipment that you need, and then a checklist to ensure that you've got the patient safely ready for proning. And we'll also have some extra protective gear in the box with surgical gowns and surgical gloves. Okay, so the first part of the checklist goes through the personnel that we need to perform the proning manoeuvre. As a minimum, we need 5 individuals. The person at the head end will be an advanced anaesthetic trainee or anaesthetic consultant, or intensive care consultant or advanced ICM trainee. They need to have the skills to be able to re-intubate someone quickly if we have an unanticipated dislodgement of the oral endotracheal tube. Then as a minimum, we need two people either side of the patient to perform the proning manoeuvre, and ideally that team is in height order coming down the patient. If the BMI of the patient's higher than 30, I would advise that we review whether we need 6 on the team. The extra person you need to think about is whether you need a runner. Okay, so then the next part of our checklist is what we need in the room or with the patient. This will include the grab bag, which has all the contents to get the patient ready, and we'll be going through that on the checklist shortly. But also we need to take in the drugs that we want for the patient, and also pillows. So ideally at least 3 to 4 extra pillows. Certainly try and get a different shape of pillows, thick and thin, so we can actually use them ideally for the patient. The drugs that we want you to take in are metaraminol, glycopyrrolate or atropine, depending on your preference, and a muscle relaxant. Ideally, that muscle relaxant will be a bolus of either cisatracurium or atracurium, as the patient is likely to be running on an infusion of cisatracurium. The other kit that we need to think about is having an airway trolley available either outside a side room or theatre, and in the bay, for example, where we are at the moment, available near the bed space. The reason we want the airway trolley is so on top of that we can have our emergency intubating equipment. We're not going to open any of it because we're going to waste a lot of kit if we do that, but we're going to have the required equipment for that patient. To ensure we've got the right equipment, at the back of every bed space there will be a poster saying what grade intubation they were, what size tube they have in, where that tube is at the teeth, and that will be easily accessible and obvious to the team coming to prone, and they'll be able to have that kit available on top of the airway trolley if required in an emergency. If the patient's really unstable and we think there's a potential for any cardiac instability, we may have the defib nearby, but that will be a consultant decision. So the next part of the checklist is about preparing the patient, and I think the best way to think about this is going from top to toe. Once we've made a decision to prone, the key thing is to turn the NG feed off straight away. You can aspirate the actual NG a little bit later, but the first thing to do is just get that turned off. And then working down from head to foot, I would put some Lacrolube or equivalent into the eyes in preparation for proning. Then you want to check the NG position and document that, and also change any Nasofix devices with a clip to a normal Nasofix with no clip on it. Next would be thinking about the airway. We would move any anchor fast to just a tube tie. Hopefully most of these patients will already just have a tube tie in place due to having had an RSI potentially on admission. What we need to do with the tube tie is make that as soft as possible, so we'll have foam in the grab bag which can be cut with the scissors that are also provided. So cut it in half, then cut it lengthways, and it will be put round the ET tube to make that comfortable on the patient's face. Clearly try and aim to have your ET tube as central in the mouth as possible. Then I'd perform some subglottic suction with syringes that will be at the bed space already. And then in terms of doing oral suction, I would wait to perform that just before you do the manoeuvre to ensure that we're not leaving any dirty Yankeesuckers around, and we're trying to keep the site as clean as possible. Moving down from the face or on the neck, where you may have a central line or other lines, you need to make sure they're sutured properly, that the dressings are in place and secure. It may be that your lines are in the groin, And the same thing will apply, that you need to make sure the sutures are in place and they're secure. At that point, you can disconnect and cap off any unnecessary infusions. For example, insulin will be stopped because you're not having the feed. Frusemide, anything that doesn't need to be running can be taken off, as well as a CVP transducer. You may want to put some Alevin over a groin line, and that's in the packs as well, to just add to the preventing pressure areas with the lines that are in place. Clearly, you're going to have to remove your ECG electrodes when you get to proning the patient, so there's some spare ECG electrodes in the pack ready for that. But moving down from the neck, you need to think about the pressure areas, which would be the nipples and knees. So we've got some Duoderm in these packs ready to dress those areas appropriately. And talking to the nursing staff, this doesn't need to be changed every time you re-supine a patient. They can actually last for several days, but if they're wrinkled or look like they need changing, please address that when they're supined. And then moving further down from that, you need to make sure that the catheter's emptied, the catheter's clamped. If we did have chest drains, they would also be brought down towards the feet and managed at the feet without them being clamped. Following a final timeout with the team, we'd put the mattress, if it's an air mattress, onto PMAX, and we would ensure that the patient's pre-oxygenated on 100%. Before we disconnect the ECG and SATS probe from the patient, we're going to do a simple lateral tilt to get the slide sheets underneath the bed sheet, and also this will help us see if there's any profound cardiovascular instability before we proceed to the proning manoeuvre. The key thing is to make sure that we don't get our wrists underneath the sheets, so our PPE stays intact and the slide sheets are up to the edge of the bed on this side that you can see. Pillow out. We'd remove the ECG electrodes and monitoring completely. The SATS monitor would be removed and the lines manoeuvred so they're going to be under the patient's arm and shoulder if they're coming from the groin, and free at the neck to make sure we're safe for transfer. And then we're going to ensure the male genitals are very central, so they're easily accessible once we've proned, so we can rearrange them so they're not under any undue pressure. And then we need to place pillows strategically over the iliac crests and over the chest, ensuring that the pillow on the chest is really only about up to the height of the shoulders or just below. So once we've got the pillows on top, it's putting the top sheet over so we can roll the patient into what we're referring to as a pasty. So the top sheet mirrors the bottom sheet and we roll from the edges inwards to the patient, keeping the roll as close to the bed as possible and ensuring we're not rolling up above the shoulders. So we leave the neck free so we can see all the lines coming out and ensure we're happy that we've got enough slack on the lines and we can have control of them. Once the legs are rolled in together, they'll take care of themselves, and the people performing the move can move to the hips and to the shoulders. Ensure the pasty's really tight to make sure the move goes as smoothly as possible. To start the proning manoeuvre, I'd make sure that the head is at the edge of the top of the bed, so you might need to slide towards the head end first. And then I would do my first part of the proning manoeuvre, which is a horizontal slide away from the ventilator, making sure that the arm and shoulder are coming just off the mattress to give you room to do your lateral tilt. Okay, so once we're in the horizontal position, we're going to do a lateral lift on command of the head end. Then one hand from the bottom goes to the top, one hand from the top goes to hold the sheet, second hand from the bottom goes to the top, and the second hand from the top holds the top slide sheet, and then on command we'll turn into the prone position. Then we remove the top slide sheet and the top bed sheet. And then using the bottom sheet, we can reposition the patient into the middle of the bed or slightly across to the side away from the ventilator to give room to swim the arms. We'll then need to use the team who are proning to lift the legs to reposition the pillow. And then the last part of the proning manoeuvre is to make sure that we've swum the arm which the head is facing upwards. So once you're happy with the final position on the bed, you can remove the final slide sheet from bottom to top. Remove it carefully as it can move the patient position. And then you need to put reverse Trendelenburg on of about 30 to 40 degrees. And we're asking the teams to stay for a total of 15 minutes following the proning to ensure that there's no instability that requires urgent resupination. Okay. So in order to swim the patient, which we are advocating every 4 hours due to the likely number of patients in a prone position requiring interventions, standard would be 2 hours, but we're going to have to prolong that to 4 hours. The first thing we'd do is neutralise the bed, so put that back in a natural position, so take off the reverse Trendelenburg. Then we would put the arm back to a neutral position. And then in order to disturb the patient as little as possible, we're going to use the slide sheets together again, but roll them into a Swiss roll. But we do this with folding rather than rolling, trying to keep the sheets as even as possible. It's important we know where the top edges are, and they need to stay up at the top of the head where we can keep hold of them. And then we're going to feed the slide sheets under the sheet with a little bit of head lift with the head end towards the opposite end, but there's no reason for anybody's wrists to get trapped. And then roll by roll, we undo the slide sheet from top to bottom, always keeping hold of the top edges. It's useful to move the sheets up from the bed so you can see what you're doing. And then straighten the bed sheet, and on the command of the head end, we can move the patient up so their shoulders are just over the edge of the bed, giving us lots of room to move the head safely. Ensure that all your lines are free and that your tubing is not connected to any tube holders. Then we're going to move the head 180 degrees. Once we've moved 180 degrees, we'll slide the patient back down the bed, leaving the head at the top of the mattress, as we've already talked about. We may need to slide the patient to the other side of the bed to allow us to move the arm on the right into the swimming position. And then we would swim up the right arm, so as we refer to it, the patient would be sniffing their armpit, and that reminds you which arm needs to go up. Once we're happy with the position and the patient stable, we'd remove the slide sheets again from bottom to top to ensure we don't move the position. And once these are removed, we'd go back into the reverse Trendelenburg at 30 to 45 degrees. So we've shown you the proning and the swimming. Obviously supining is essentially reversing what we've done for proning, with the checklist being completed and ensuring that we are disconnecting all the monitoring, making the line safe to resupine and disconnecting the unnecessary infusions at that point. key principles of this manoeuvre are ensuring you have your airway adjuncts available for an unexpected extubation, and if that does happen whilst the patient is in a prone position and nobody is actually there, the key element we need available is an eye gel, as that's what we would use as our emergency kit to get a definitive airway, and then we would obviously be alerting teams as an emergency to re-intubate as quickly as possible. In a COVID patient, we need that head end person to be in their enhanced PPE, and we would ask the other team members to step away if we were in the midst of doing a proning manoeuvre.